Welcome to Research Renaissance, presented by the Karen Toffler Charitable Trust. Embark on a journey into the forefront of cutting-edge brain science as we feature insightful discussions with a diverse array of guests, from early career researchers pioneering groundbreaking science to influential voices in investment communities, policymaking, and research institutions. Together, we delve into neurological diseases, their causes, treatments, and the quest for cures. Join us in advancing our understanding of the brain and addressing its ailments. Welcome to Research Renaissance. I'm Deborah Westphal, your host and guide through the fascinating future of the brain. Joining me today is Dr. Maria Nagel, a professor, clinician, and scientist in the Department of Neurology at the University of Colorado. Today, we will discuss Maria's focus on understanding how viruses affect the nervous system that result in various diseases. So let's dive in. Welcome, Maria. How are you?
Thank you, Deborah. Thank you for inviting me to share our work.
You have a very interesting perspective on understanding diseases that affect the body. Can you start and tell us about this?
Yeah, thank you so much, Deborah, for inviting me to share our work. I am actually a neurovirologist, which is a neurologist that studies how viruses affect the brain and the spinal cord and the nerves coming out of the spinal cord to produce disease. I specifically focus on varicella zoster virus, or VZV, which is one of 8 human herpes viruses that infect the majority of the population and stay hidden in our body or latent. And then throughout our lifetime, they'll intermittently flare up and cause disease. And so VZV specifically causes chickenpox when we first get it, also known as varicella. And then decades later, when we're older and our immune system is weaker, it'll typically flare up and produce shingles, also known as herpes zoster. But my lab studies additional manifestations of VZV, such as stroke, which is called VZV vasculopathy.
So that's interesting. So how many neurologists are out there that actually study viruses? Is this a pretty rare focus in research?
Yeah, it actually is. There are many basic scientists that study neurotropic viruses. For instance, SARS-CoV-2 can be considered now a neurotropic virus because it can cause long COVID and, presenting in some ways with headaches or fatigue or a constellation of symptoms. So there are basic researchers that study viruses that can affect the nervous system, but there's really not as many practicing clinical neurologists that are also experts in the field of neurology.
So when people hear that you're studying the herpes virus, there's maybe a misunderstanding that there's these 8 different types of herpes. And, because we see it on TV, we read things. Can you go into a little bit of just what are the differences and why is the virus that causes chickenpox kind of your area of focus?
So first, just a little funny story. It's really hard for me to say with a straight face in parties that I am a herpes virologist. Because, herpes viruses in general, people think herpes, they think, genital herpes, STDs.
Right.
And so there's, some kind of, interesting things that happen when we go to our international herpes virus meeting at the airport. You don't see welcome signs for welcome international herpes virologist. You say, oh, welcome IHW. Okay, an abbreviation. So, but it's actually really not an STD. People think about these as STDs, but these are really 8 viruses that are just commonly acquired, typically airborne, or we share, it's shed in saliva, we share in the spoon. So varicella zoster virus that causes chickenpox, shingles, and other diseases that I'll talk about later is very closely related to the herpes simplex virus type 1, which we think of as cold sores, and herpes simplex virus type 2, which we think of as causing genital herpes and genital lesions. But they actually, the manifestations of those viruses are much more broad. HSV1 and VZV can cause recurrent eye disease and blindness. They're the most common cause of infectious blindness in the United States. HB2 can cause recurrent headaches. We've actually found that 3% of our chronic migraineurs in our clinic are due to HSV reactivation without the typical cold sore lesions. And so I study the family called alpha herpes viruses, which is VZV and HSV1 and 2. But the other herpes viruses are Epstein-Barr virus, which causes mononucleosis and fatigue and has been associated with some of the patients with COVID, perhaps contributing to the long haul symptoms. EBV also causes head and neck cancer. And if it's continuously present in the bloodstream, if it's flared up, such as in children in Africa, it can actually cause a Burkitt's lymphoma, which is a type of cancer. Other herpes viruses include CMV that can cause birth defects, and it can cause some brain infections and some eye disease in immunocompromised patients. HHV6, we're still looking for a disease, but it is associated with heart manifestations. And HHV8 is what causes Kaposi sarcoma in HIV patients. So these viruses, we actually harbor, the majority of the population, we harbor these viruses in their body. They're dormant in us. And again, they'll just, depending on your genetic background and, how robust your immune system is at keeping them quiet, they can flare up and they can cause disease, or they could subclinically flare and you can just transmit them via saliva, for instance.
So when you say they can cause diseases, what is that mechanism? I mean, how does that happen? And how does the disease manifest, especially given your focus, which is the VZV virus?
Yeah, so I'd like to make a distinction about infectious disease and viruses, like what we deal with in the clinics. So most of us think of diseases produced by viruses that are coming from the outside. Right. So you get SARS-CoV-2 from someone else, and then you develop a pneumonia or just mild cold symptoms, or you get the flu from someone else because they sneezed on you. And so those are things that you're getting from the outside. These herpes viruses are unique in adults because we've typically already acquired them and they're dormant in us. So it's not that we're acquiring them from outside our bodies, it's that they're in our bodies and then they're flaring up. And depending on where they flare up and what organ they travel to, that's the disease that you'll get. So I'll specifically talk about varicella zoster virus and HSV because those are the closely related viruses. And what's really unique about them is that they establish latency where they're completely silent, they're hiding out, your immune system can't see them and clear them. They actually hide out in neurons, clusters of neurons in the head and neck, the cranial nerve ganglia, and your fight or flight response neurons. They're in clusters of neurons or sensory ganglia along your entire spinal cord. About 5% of humans have them dormant in their adrenal glands. Ann and Mike Gershon at Columbia University had done some excellent work where they characterized that VZV in particular is dormant in the neurons that line your GI tract from esophagus to anus. And that GI tract, those number of neurons, there's actually more neurons there than the spinal cord. And that's why your enteric nervous system is like considered your second brain. And so these viruses reside in those neurons and are silent. So when they flare up, for instance, in the cluster of neurons, the trigeminal ganglia on the right side that controls sensation in the face, then you'll have facial pain and typically a rash by your eye for varicella zoster virus. If VZV flares up in the enteric ganglia along your stomach, it's not going to get to the skin because it travels along nerve fibers. It doesn't go to the skin. What it can present as is an ulcer, or it can cause chronic constipation because it interferes with the ability of your GI tract, to move and get, have those regular bowel movements. So it really depends on where the virus flares up and then the pathway that it takes along nerve fibers to be deposited into whatever the end organ is. And what's super fascinating to me is that, when you think about it, we think about VZV only causing shingles, right? We think, oh, when the virus flares up, it travels along these nerve fibers outwards to the skin, and then, a little rash pops up filled with fluid and it hurts. And sometimes if the pain persists, it's called post-herpetic neuralgia. And that's the most common cause of suicide in chronic elderly pain patients. But the thing is that those nerve fibers also go inwards, and every single organ in our body has innervation and the majority of our blood vessels. So there's actually a highway from these neurons where VZV as well as HSV are dormant, that when they flare up, they can travel along different highways that, for instance, may end in the eye, and it can cause corneal ulcerations and inflammation and blindness. My lab specifically looks at how VZV can travel from trigeminal ganglia inwards to the arteries in the brain, and then inflammation occurs, and you either get rupture of the blood vessel, so that's hemorrhage, or the blood vessel can remodel and the area where the blood flows through can get closed off, and that's called ischemia. So VZV can produce both an ischemic stroke or a hemorrhagic stroke because the virus has traveled along that highway that deposits it into the arteries in the brain.
Do we know why these viruses flare up?
We do. It's actually very, very interesting. So they flare up when our immune system is weaker. Unfortunately, as we age, our immune system, becomes a little less robust. And in a sense, these viruses are sensors for how healthy their host or home is. And I think, one of the simple ways I explain to my children, what I'm, about reactivation, it's like the virus that's been asleep in this house sees the house is falling apart, because, the immune system's not working so well. Something's wrong with my house or my human host, and so then it wants to flare up and spread to another host. And so we see with aging, our immune system becomes less robust. And so about 50% of us will actually reactivate and get shingles by 85 years old. Okay, it's common. 95% of the world population harbors VZV latent. 50% will reactivate by 85 years old. Okay, so what are other things that can suppress your immune system? Well, cancer. So I see newly diagnosed cancer patients that will first present with shingles, or they'll have cancer and then get shingles shortly afterwards. Drugs. So immune suppressive drugs like those for multiple sclerosis patients or patients with autoimmune diseases or cancer patients undergoing chemotherapy and radiation therapy, transplant patients who are on anti-rejection meds. Those medications, weaken the immune system in those situations, and then the virus can flare up. So in general, it's a weakened immune system. We've also seen trauma flare up the virus. I've had cases where someone had like a little skin biopsy by their belly button, and then they'll get shingles in that same area within 24 hours. And so there's some nice data on that showing that aside from immune suppression, that trauma can also reactivate virus at that site of the trauma. And then finally, I think that so we have immune suppression, we've got trauma, chronic stress. So we all know that chronic stress can affect our immunity, and that can contribute to virus reactivation. But also, some of these herpes viruses actually have stress hormone response sequences on them that stress hormones can turn the virus on and or wake it up and allow it to flare up, particularly Epstein-Barr virus, which I had mentioned before had been associated with long COVID, and more recently, it may accelerate multiple sclerosis progression. That's an area of research right now. People are trying to determine, is that true or not, and what's the mechanism if it is.
Yeah, so that's interesting, especially the stress. Is there enough data, over time, going back a couple decades, with the increase of stress in our daily life? Do we see an increase of, a weakening of our immune systems that kind of lead to some of these, flare ups? Is there a correlation to the outside environment that we live in, or do we not know?
That's actually a fantastic question. We don't know because we don't test for it. We only typically think of flare ups causing rash, right? So for VZV, we think, oh, they have a rash. And now, we have two different shingles vaccines. We have originally Merck's Zostavax and now GlaxoSmithKline's Shingrix vaccines. We have the vaccine in play. We've got the chickenpox vaccine, Varivax, also in play. We think of reactivation as something visual that we see, right? Like that they're going to end up having a rash. But reactivation can occur without rash. And so I believe that we're missing a lot of it, particularly Epstein-Barr virus. I've started testing for that in some of my patients, several college students actually that I have that have incredible amounts of stress, and then they present with a sore throat. It's not bacterial, it's not strep throat, it's not fungal, it's not candida. Can't figure it out, but they've got foggy brain, severe fatigue, and large lymph nodes. Essentially, it's mononucleosis. And for some reason, it's frequently missed. um, and so I've been actually testing when I have people saying, hey, it's different. Like I got a fog, something happened. I had some type of cold symptoms and this kind of lingering enlarged lymph nodes and fatigue. So I actually test for EBV DNA by PCR of their blood. And then I also test for the antibodies. So again, kind of like a short response to your question is that we actually don't, in this period of super high stress, right? I mean, when you think of our society, COVID, lockdown, this, epidemic of loneliness in the elderly, and just kind of, our environment, we're under so much stress, and I think we haven't looked. We actually haven't looked, and it's actually like a fantastic little research project for a student.
Yeah, do you ask when people come into your clinic and your patients, do you ask them, how's your life? Or, because I don't know what you can ask as far as, their financial burden or just the stress that they have in their daily life. Is that something that you can kind of track, or is that really kind of off the table?
I do track that, but remember, I have a specialty clinic. So my clinic's biased. They're already seeing me because they suspect they may have an infection. And then I hear about their 5-year long history, of all the events that happened to them. But when we do treat them, like I have a patient who has recurrent HSV1 reactivation events that present as not cold sores, but it presents as a burning mouth. And then on her right cheek, she'll intermittently get something that looks like a spider bite, not like a classic fluid-filled cold sore. And then she'll get pain in that region, and we'd had her well controlled with antivirals, and, it had gone, her symptoms resolved. But when it came back with a vengeance. She also had GI tract involvement, chronic abdominal pain, burning mouth, cheek hurting, foggy brain. And she was under an incredible amount of stress. because I was like, what is going on? And she's like, well, just, her life situation has changed. Then also she had been diagnosed with cancer.
Mm. Mm.
So I was like, okay, the cancer may have suppressed her immune system that flared this up. In addition, the stress can also suppress your immune system. You get release of glucocorticoids. That may also contribute. So I do actually ask that of my patients. But I remember I have a biased clinic.
That's true. So can you test for where the virus resides in the body? Because you said where it resides is kind of where it will erupt or manifest. Are there tests to see where the virus is maybe laying dormant or where it may be at before it erupts?
Yeah, so this actually had been done on autopsy studies by Peter Kennedy out of Glasgow, Ravi Mahalingam here in Colorado, and Don Gilden, and other researchers that I don't know everyone, but those were the key people that looked at autopsy findings, and Sally Atherton also. They looked at autopsy findings and found that VZV pretty much resides in all of those ganglia. And HSV also, but predominantly in the head and neck region and in the genital region for HSV too. So whenever I see some unusual disease, usually I get patients where they've seen at least 20 different specialists that can't figure out what they have, and then I think, okay, well, you've got a right arm weakness without a rash, but there's a lot of pain. So could VZV have reactivated from the right cervical ganglia that sends that sensory innervation to your arm? And then, so then I just check their blood to see if they're having a robust immune response to VZV, indicating that they're actually having a flare up.
So you're also a neurologist, and that's around the brain. What is the relationship with these viruses and brain diseases?
Yeah, so a large focus of my work since 2006, when I mentored under the late Dr. Don Gilden, was looking at how VZV could cause stroke with or without the shingles rash. So you may see an older person, so where they just present with a stroke and they keep having recurrent strokes, and they can't figure out why, and then we would get called about it, and then we'd say, okay, well, get the spinal fluid, let's check to see if there's antibodies being produced in the spinal fluid against VZV, and this could be a vasculopathy without rash. And so we have many cases of those, and so that's what I originally started my focus on. Actually, in children, one of the most common causes of arterial ischemic stroke is varicella zoster virus. Typically, after chickenpox, kids would develop stroke about 7 to 8 weeks later, after the rash had already resolved. And so it's actually, we believe, not as uncommon as we think it is. But what happens is when you have, in our current environment now, when you have an older person that has a stroke, you're like, oh yeah, they were obese, they were smokers, they had high cholesterol, they never exercised. Of course, they're going to have a stroke, and no one really, looks at a potential for, could there be a virus player in there? So that's not part of the thought process. Now, many, many years ago, when syphilis was more common, neurologists actually did lumbar punctures on stroke patients to look for the organism that produces syphilis, because it was a common cause of stroke. But with the advent of antibiotics, and we rarely see syphilis anymore except in the HIV population and some intermittent spikes here and there, we don't really think of infection contributing to stroke. But we really, our group here in Colorado has really worked on characterizing how that happens and the mechanisms. And there's several other groups in the U.S. Out of Mayo Clinic, at University College of London, in the UK, and in other countries in Europe that have actually done epidemiological studies that shows, hey, after shingles, you're at a significantly increased risk of stroke for the next year. And interestingly, some of those studies have also noted that with shingles, you're in an increased risk of dementia over the next 5 years.
Yeah, I was going to ask you, what is that relation? If the virus can cause strokes, what is that relation to dementia, Alzheimer's, Parkinson's, possibly ALS? Do we know if there's a connection, or this is something that you're studying too? Is that correct?
Yeah. So, so with the progression of I guess, discoveries, it frequently starts with clinical observation cases like, oh, I had somebody who had shingles by the eye and then they ended up with a stroke on that same side of the brain. And then it progresses to larger epidemiological studies where we looked at 20,000 patients that had shingles, 20,000 that didn't, and how many of them ended up developing dementia or stroke or other diseases. And oh, yes, that's statistically significant. It seems to be associated when you control for all these other comorbidities. And then it goes down into the lab of, well, that's a neat observation, but is there actually a mechanism that we could explain for how this would work? And so what we've been looking at is mechanisms. And so a large portion of my lab, it's pretty exciting, is we're seeing an intersection between what I had spent my time on, which is VZV vasculopathy and stroke, an intersection with dementia. And this was pretty new for me. We just started looking at dementia a few years ago. I was just interested in stroke. I wasn't really looking at dementia pathogenesis. And so I just started learning, and reading up on the field. And, dementia is a broad term. We've tried to categorize the different types of dementia and put them in separate buckets. Like, oh, here's Alzheimer's disease. Here's Lewy body dementia. Here is vascular dementia. Oh, here's mixed dementias. But now what we're seeing is actually more frequently mixed dementias. Like many Alzheimer's patients, when you examine their brains after they pass, will also have some components of vascular dementia. Or, you might have someone that predominantly presents with hallucinations characteristic of Lewy body, but then they're also having some features of Alzheimer's disease. So we're actually seeing a mixing. It doesn't like fall into these clear buckets. Like this is this one type of dementia, this one type of dementia. And so what we're working on now is more how we know about Alzheimer's disease. We know what the features are for Alzheimer's disease and vascular dementias. So how does varicella zoster virus and its sister virus, herpes simplex virus, because that also has been shown on epidemiological studies to be associated with dementia, mechanistically, can they contribute to the features we already know exist in Alzheimer's disease? So, for instance, in Alzheimer's disease, can these viruses increase the amyloid burden and make more amyloid, or contribute to more amyloid accumulation? And amyloid itself is toxic to the surrounding neurons, and it can interfere with signaling. And if those are neurons involved in memory formation, cognition, then you'll have cognitive deficits or speech. You'll have speech deficits. And they're also very inflammatory. So like, okay, we know Alzheimer's disease, has amyloid deposition. Do these viruses increase amyloid deposition? We know that there's these hyperphosphorylated forms of tau. Can these viruses cause that? What we know that Alzheimer's is characterized by neuroinflammation, lots of inflammation. Can these viruses contribute to that? And so we just, so that's how we're approaching the issue. And then we're trying to see, okay, well, in cells in a dish, and if we infect them, do we see more amyloid form? And do we see inflammatory markers? So we start with that. And yes, we do. We do see that VZV and HSV1 can cause amyloid to appear in the cells that are infected. And we could see that there's a really robust inflammatory environment around those cells in a flask. And then we started looking at animal models of infection, which is a little trickier. Animals don't recapitulate humans, but they're the best model we have. So we've used some mouse models and some rhesus macaque models to see if if one of the key features of Alzheimer's disease is there's hypometabolism or a decreased glucose uptake in certain areas of the brain. So if we infect or give the monkeys chickenpox and we do a PET CT with tracers for glucose, do we see similar findings as we see in Alzheimer's? And we do. And so, we're still in those early stages of kind of our progression from case reports, epidemiology from, these are from a lot of different contributors, scientists and clinicians contributing to this body of work, and I think we're just still trying to understand, well, how is virus going to contribute? And more importantly, what does the host background have to do with it? Like there's an interplay. Like if all of us have VZV, why aren't we all demented? There's going to be host factors in play, and there's also going to be lifestyle factors in play. So now, I think one of the challenges with Alzheimer's disease and the dementias is that it's not a single cause, right? Like we know that you get a heart attack because, your heart is a muscle and the blood flow to it gets clogged off, and then your heart muscle, doesn't get enough oxygen, and it gets injured. Okay, that's a heart attack, right? But with Alzheimer's, it's very different. It's like, okay, you get multiple hits from different pathogens. I mean, we're not claiming that it's only VZV and HSV. I believe that multiple other pathogens, potentially SARS-CoV-2, can also induce an amyloid state and cause protein misfolding and neuroinflammation. But it's more like throughout our lifetime in a genetic background, like I've got a different background canvas than you do. And we get multiple hits or splatters of paint from different pathogens, and then we live our life a certain way, that then the end result is going to be neurodegenerative disease or, healthy aging.
Do you have support for this? Because it sounds like it's new. It's an emerging focus in research to add to the body of knowledge, not to counter what's already existing, but to add to. Is there a pretty wide support for this kind of line of research, or do you feel sometimes like you're swimming upstream when you bring these hypotheses or you bring this data?
I think a decade ago, it was a little bit kind of far out, and a lot of that I think is because there were some early reports where maybe perhaps the interpretation wasn't as cautious, and a pathogen was noted to be the cause of Alzheimer's. And so that line of thinking kind of, I think, colored many scientists and clinicians' view of the field of virus contributors to neurodegenerative diseases. When there were original claims of, chlamydia causes Alzheimer's, or, this virus causes Alzheimer's, or this fungus causes Alzheimer's. And, and I think it, really and then there was also, I think a lot of work on, a focus on the amyloid hypothesis in Alzheimer's and accumulation of amyloid. And so there was, I don't want to say a fixed mindset, but, there was a certain belief that we had as scientists from previous literature. But then what happened is that there started to be some great larger epidemiological studies, and case reports that came out that was like, maybe this is worth looking at. And, a lot of exciting work that the National Institute on Aging actually became quite interested in this. And they actually have a special call for grants on microbial contributions to dementia now.
Well, and the linkage is, as I understand what you just said, is through maybe inflammation and what that inflammation does inside our brain or inside our cells. And that's what you're trying to understand, I believe. Is that correct?
Yes, yeah. So we think that VZV and HSV contribute to dementia via a multi-pronged system. It is increasing the amyloid burden. Those viruses can increase the amyloid burden by stimulating production and slowing down our ability to clear it, to clear these aggregates. Okay, and part of that mechanism for slowing down the clearance is affecting cells called microglia in the brain. And this is just, we're still again in early stages, and there's, many other virologists out there and neuroscientists and Alzheimer's disease specialists that are adding on to this body of work. But from what we're hypothesizing is that these viruses, particularly when it flares up multiple times, can affect the function of microglia, which is what normally would clear these aggregates. And so then over time, with multiple hits, the microglia become dysfunctional. So they don't clear these protein aggregates as well. And these protein aggregates, remember, are toxic to the surrounding neurons. And at the same time, these microglia promote a chronic inflammatory state, like chronic inflammation there. It's very damaging to cells. They're not doing their job properly. And so that's one of the things that we've been focusing on is like, why is there this aberrant inflammation? Is it that the virus is recurrent virus hits or recurrent pathogen hits? Maybe it's not one virus, right? Maybe it's, you got EBV, then HSV, and then you got SARS-CoV-2 on top of that. All of these multiple hits to these, defenders in your brain, these microglia, eventually cause a permanent phenotypic change in them. So they can't function normally anymore.
Yeah. So you've mentioned chickenpox and you've mentioned shingles, and I know we have vaccination against shingles. Do most people get the shingles vaccination? Do they or do they not? What, as a clinician, what is your recommendation for people when it comes to the shingle shot?
Yeah, so right now, the CDC is recommending shingles vaccination for patients 50 and older. The new vaccine, Shingrix, is pretty effective in decreasing your risk of developing the rash and the subsequent postherpetic neuralgia or pain that occurs. However, many of those trials didn't look at the other outcomes, such as dementia and stroke, the original studies. So then in the recent years, with association of VZV, VZV reactivation manifesting as shingles, also known as herpes zoster, that association with stroke, then there's been several studies that have shown that vaccination actually decreases the risk of stroke. And there's been some tantalizing studies, but they have to be, I think, more studies need to be done with regards to the shingles vaccine decreasing your risk of dementia.
Yeah.
I would add, though, that with regards to the shingles vaccine, you have to talk to your family doctor, because some people, they may have certain medical conditions that, it may not be appropriate. It's a very inflammatory vaccine. If you recently had shingles in the eye, or a VZV keratitis, and the disease is still not quiet and there's still a little virus there, it's not recommended that you get vaccinated right away, because you can then get, a really strong immune response if there's residual virus still in your eye that can be more damaging. So you have to talk to your doctor for them to really look into your other conditions, your other inflammatory conditions, medications you're on, whether you've had previous bad reactions to vaccines. I've had some patients that had Guillain-Barré syndrome, post-vaccination. So we always really just kind of discuss, very carefully the risks and benefits of getting that Shingrix vaccine.
Yeah, really good recommendation there. And it's just interesting, the possible connection that we may you may learn in the next few years is to, something that could maybe slow down some of these neurological diseases. And they may come through vaccinations to help with that at least.
Yeah, yeah. And I would say that this line of research, part of the reason that, we got into this Alzheimer's dementia research was because really there's no cure for Alzheimer's, right? By the time you're diagnosed, you're already having some mild cognitive impairment. Other people are noticing. You eventually get in to see a neurologist after a 3 or 6 month wait, because there's many communities where there's just not many neurologists, and there can be a 3 to 6 month wait to get in. It's very difficult when you've already had some significant neuronal loss and damage that actually presented clinically to reverse that. Many of the drug trials for Alzheimer's disease, they don't reverse disease. You don't suddenly get your cognition back. Our best hope is that it slows the decline. So you've already come to the doctor, you already have cognitive deficits. There's new drugs that come and go in the market. They have clinical trials that, it works, and then they have a side effect of hemorrhage, and then it's pulled off the market. We've had a lot of Alzheimer's drug trials, okay, and that are promising, and there's a few promising ones now, but they're not curative. You're not going to go back to normal once. The hope is that we can slow progression, maybe have a little bit of improvement. But maybe in the future. I'm not saying it's not impossible. It's but we've had decades and decades of research in Alzheimer's disease, and we don't have a drug yet. We put in, billions and billions of dollars, and we don't have a drug yet. So our approach is to say, well, we know the disease starts 20 years later. People lose their sense of smell. Things start happening in their brain 20 years before there's enough neuronal loss that they present with cognitive decline. So what can we do? What can we do to say, okay, well, what are the things 20 years prior? What are the risk factors? What are the things that are going to accelerate progression to the actual clinical diagnosis of Alzheimer's disease or the related dementias? And so, for instance, exercise, can slow down disease progression, controlling your diabetes. There's actually several risk factors that have been identified that increase Alzheimer's risk. And we say, okay, well, if, smoking or obesity, can contribute to risk, let's address those. And so our approach is, what I think the field is trying to do, the neurovirology field is, okay, well, what are viruses and maybe other pathogens, not just viruses, bacteria, what are other infections? What infections are contributing and accelerating progression of disease? And is there any way that we can prevent those infections through vaccinations or aggressive diagnosis and actually, treatment with antivirals and, aggressive treatment with antibiotics or prophylactics, that then we can slow that time from the disease formation to actual clinical presentation. And so that's how we're pushing it. We're not claiming that, VZV and HSV are the sole cause of Alzheimer's, right? It's in the, setting of the host's genetics and their lifestyle and their other risk, that includes their other risk factors. But if VZV is so common and it reactivates in so many of us, what impact can we have if we, convince ourselves that, yes, it really is contributing to acceleration of Alzheimer's and related dementias? What impact can we have if we can treat more aggressively with antivirals or vaccinations? Right now, the vaccination rate for those that qualify is slightly under 30%. So about a third of people get vaccinated against shingles, and 2/3 do not. So I think there's, studies that will be emerging, or hopefully studies will be done that'll more firmly determine whether vaccination can reduce the risk of dementia, and at the same time also making sure that vaccination is safe. right? Because vaccination can be a hot topic, and you want to make sure that it's safe in general, but also safe for the individual, which is why that individual needs to work with a doctor they can trust and really, really look and see, is vaccination appropriate for me?
Yeah. And as you were talking, I was just, Alzheimer's, dementia has become a disease of aging, of the aged. The way you were describing it is, if we could go back, if we could understand it before it even starts to manipulate or manifest in our body, we might be able to slow it down or possibly just, stop it from progressing, which is not a disease of the aging or the aged. It also includes the youth, and, it's 20-year-olds, it's 30-year-olds, 40-year-olds. It's not just, 70-year-olds or 80-year-olds. So it's very important work to understand the why. And that's what I hear you really focusing on, is why is this happening? What part of the broader aspect of just living is contributing to these things? And, how does it manifest individually in each individual? Because we're all very different, genetically, as well as you said, experience wise.
And that kind of goes into a broader topic of aging, which is also, I think, of great interest with NIA, biomarkers of aging. And there's this, concept out there that, as we age, we have disruption in homeostasis, that, our immune system doesn't function as well, our ability to clear, toxic proteins isn't as good, our energy production isn't as good. And so we get this decline with aging, and that because of that decline, we end up with cancer, Parkinson's, Alzheimer's disease. And so there's an entire field out there of, well, how can we understand this aging process? What homeostatic mechanisms are being disrupted? For instance, our ability for DNA repair, is it less robust? And how is that contributing overall to the production of these diseases of aging? And I think that's another really exciting field that's going to really take to the forefront in the next decade. There's incredible amount of interest in that.
So what was your interest? Where did this start to focus on viruses, neurology, the combination? Is this something that just happened over time, or was this really a focus from your youth?
Yeah. So this was, I think, I mentor a lot of young, like elementary school students all the way through pre-med students. So what I found, like, I am where I am now, where, I love my job. I love what I'm doing. I love the people that I work with, our colleagues, the excitement of new research directions, the ability to establish collaborations. But it wouldn't have been possible if I didn't have such fantastic mentors in my life, which is why, like, I really try to take an active role in mentoring, because, just having an hour meeting with someone or making a recommendation of what their path should be can really change the outcome of what their ultimate career would be. So for me, it was just pure luck, that I ended up with some fantastic mentors, that I ended up in this field. So, one of my mentors was Hans Schreiber at the University of Chicago, and he does tumor immunology, and I worked with him as an undergrad. And he really inspired me to do both translational research and to enter into the medical field. And so I worked with him for quite a while doing some tumor immunology research. And he's like, oh, get your medical degree, because then you can look at your basic research with a lens of a clinician. So you could, maybe design your experiments a little bit to be more translational, maybe have a little bit more direct impact on patient care, kind of thinking a little bit differently about it with that kind of medical background. And so, through Hans Schreiber, I ended up at University of Illinois in Champaign-Urbana. So from University of Chicago to University of Illinois in Champaign-Urbana, I did some research there with David Shapiro, because I did love being in a lab. I finished my medical degree, and it was just by pure chance that Dr. Don Gilden who was the chairman of neurology at University of Colorado, was giving a grand rounds lecture at University of Illinois, middle of cornfields, and I met him, and he's like, he knew I was interested in neurology. He said, you should come to Colorado. And I was like, okay, I vacation in Colorado all the time. So I ended up in Colorado in neurology, and Dr. Don Gilden was really, one of the key researchers, or if not the main researcher in the field of VZV and neurological disease. And he characterized a lot of the initial stroke mechanisms and the wide spectrum of other diseases produced by VZV. And so after residency, I stayed on with him and did my neurovirology fellowship. And then I established my own lab, and we had quite a productive collaboration with Dr. Gilden and the rest of the team here at the neurovirology team here. And that's where we are today.
That's amazing.
It's really, really, really mentorship that you kind of end up frequently in the path that we're in.
Yeah. What does mentoring elementary school students, what does that look like? Is that just exposing them to science, scientists, you being a doctor? Because that's important too.
So it's suturing bananas.
Suturing bananas. That's awesome. What is that?
It's just, you want something to engage like the fourth graders and stuff. So we're like, okay, come to our pathology department. Like just, many of them don't even like know the different organs or they've only seen cartoon figures, if at all. Yeah. And we're like, okay, here's a brain. This is a healthy brain. Here's a brain with stroke. And like part of the brain is like all black and like shrunken. And it was like, oh, here's a normal lung. This is what happens when you smoke. And so it's like hands-on experiential learning. And, that really makes an impact on them. They have lots of questions like, how come like the brain is all black from the smoker and I'm not going to smoke ever again, and so we actually do hands-on lab work with them. And then we're like, oh yeah, like let's do a fun activity. It's like, some doctors are surgeons and they stitch things up. So, from surgeries. So we're going to let you be a doctor and stitch up a banana. And so we cut the little banana skin. We give them little needles. They're really careful, and we teach them how to stitch up a banana. But it's a fun activity, but it actually makes a great impression, like a huge impression on like a fourth grader.
Yeah, that's amazing. That's amazing because
I think I want to be a doctor.
That's great.
And because many of them may not have doctors in their family, they have no idea how to even approach it. And so that's one thing. And then the other kind of like little fun projects I've done is with high school students, and usually try to tailor it per their interest, right? If you're that you want a mentor that can also kind of work with you in your interests. And so I've had high school students that come through that were more interested in public health. So it's like, okay, why didn't we do a survey monkey of all the grandparents in your high school and ask them if they got the shingles vaccine? Let's look at their ethnic background and also the reasons why they didn't get it. Like, oh, this certain group didn't get it because their doctor never told them, or they totally don't trust their doctor and they think they're just out for their money, and so we do fun little projects like that. And then I had somebody who was interested in psychiatry, and I was like, well, let's look at viruses that mimic psychiatric conditions, that mimic schizophrenia, like syphilis, that they can look demented, and so just really for me, mentorship is really fun. But a big part of why I am where I am, and I'm just so grateful for that, is just the people that I've those specific mentors that I mentioned, but there were also other mentors along the way that I haven't mentioned.
Yeah, you can hear it in your voice. You can hear it in your voice how passionate you are to kind of pay that forward and repay it. That's really amazing. So as we kind of wrap up here, and because this has been just fascinating, what's your greatest hope for the next maybe 10 years, 15 years? Where do you think the science is going to go, or where do you hope it goes? And what are you really hopeful for?
I am really hopeful in our interest in multidisciplinary collaborations now, because I think a lot of fields that may have been stagnant in the past are reinvigorated when people from different fields enter it and bring in new ideas. So for instance, in this Alzheimer's research field, I'm bringing in a new lens of viruses that can invade the immune system and how it can cause inflammation, contributing to pathologies. I have another collaborator, Diego Restrepo, who specializes in smell. And he's entered the field of Alzheimer's disease research because we see that many patients early on in disease actually lose their sense of smell first. In other neurodegenerative diseases, also like Parkinson's and dementias, there's a loss of sense of smell. So he's bringing in a different perspective of what's going on from our environment as something a virus or pathogen goes up our nose into the entorhinal cortex and hippocampus, like how is it affecting or contributing to neurodegeneration. So I am really hopeful that we're now starting to see a lot of cross collaborations and multidisciplinary collaborations, because that really kind of just, lights a new fire in the specific fields that may have been stagnant, where we just haven't had a lot of progress in the past few decades. So I'm very hopeful for that. And then one of, I think, my wishes is that more people, it's another whole podcast topic itself, that, I would hope that we could inspire more individuals to enter the field of neurovirology, because, I am on the board of the International Society of Neurovirology, and there are only 200 members. And when you think about it, many of the pathogens that we encounter there, the ones that affect our cognition, that in turn affects our quality of life, that's like a big struggle. And we just don't have a lot of dedicated researchers now in the field of neurovirology. It's challenging to do, financially and time wise. So after medical school and residency, people just want to get a job and start making money. They've been in school for so long and they've got so much debt. It's really risky to go into an academic career and hope that your grant is one of the 10% or less that gets funded and that it's continuously funded. Otherwise, you don't have a lab anymore. And so I am hopeful for the future that we'll be able to work on some creative solutions for increasing the number of clinician scientists in there, not just in the field of neurovirology, but in other research fields, and that we continue this rise in multidisciplinary and cross collaborations.
Yeah, that's wonderful. That's wonderful. Is this 200? Is this global, or is this the United States?
It's global.
Oh, wow.
Part of it is, there's a bunch of other neurovirologists out there, but they may not be able to afford the association fees. They might be more like, okay, well, I'm going to pay for the American Academy of Neurology instead of the neurovirology group. But it's really a great, the International Society for Neurovirology is actually, a fantastic group that has a conference every 18 months. And we have both clinicians and scientists and program officers from the NIH there. And, I'm just hopeful that we will be able to inspire more young people to enter to become clinician scientists and enter the field.
Yeah, and I really appreciate you talking about, this multidisciplinary collaboration that, as I talk to people, as the Karen Toffler Charitable Trust continues to mature their kind of focus, that seems to be something that really needs to be facilitated, because these problems are really hard. And as you said, if people stay in their lanes of research and don't kind of venture in or learn other kind of channels of that research, we may never find the answer. That the answer may be within those seams between some of these focuses or functions.
Yeah.
Yeah. Wonderful. So if people are listening and they're very interested in what you do, maybe interested in helping you with funding, maybe as a patient, how do they get a hold of you?
So, at University of Colorado, you can find me there, at maria.nagel@cuanschutz.edu. And I have I'll forward I'll typically forward their emails to my scheduler. Frequently, I have patients that cannot fly out to Colorado to see me. So what I have done is I've set aside time every Monday to talk with their physician. So if they have a physician, in their hometown that's willing to work with me and discuss their case with me, then I have that time set aside on Monday to talk to their docs. The patient can be present too. And then we can come up with a game plan for diagnosis and then potentially a treatment.
Wow, that's amazing. That's fantastic. This has been a real pleasure for me, and we've talked a couple times before this podcast, and every time I chat with you, I learn something, and it becomes even more apparent to me that this is really important, and what you're doing is just really special. So thank you very much for the time and just making this really clear for me and for other laymen, out there, lay persons that are interested in this area and what you do.
Great. Thank you so much for inviting me. I really had fun.
Thank you for joining Research Renaissance. For more information and to stay updated, subscribe for more episodes and visit our website at tofflertrust.org. Feel free to call us if you have any thoughts, suggestions, or just want to find out more about the Karen Toffler Charitable Trust. Until we meet again, onward and upward.